এখন কিন্তু আমরা লাইভ স্ট্রিমে আছি।
ওকে
সো মানে there will be people who join, মানে people who are not part of this group who are now entitled to join.
ওকে ওকে
7টা বেজে গেছে, সো আই থিঙ্ক একবার আমি মিউট করে শিলাজিতের সাথে কথা বলে নিচ্ছি।
হুম 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 হুম
থ্যাংক ইউ রুদ্রজিৎ, আমি তোমার মেসেজ পেয়েছি that we are live. ওকে। আচ্ছা, we've been asked to start off in 3 minutes. So it's 2 minutes past 7. We will start at 4 minutes. So 2 more minutes to um, get all the nitty-gritties sorted out, and then we'll start. So, guys, I'd like to invite you to this session on borderline resectable pancreas. And we have one of somebody I consider a terrific surgeon and a fount of knowledge, Dr. Sanjay Mandal. He is an MS, DND, MRCS, and an MCH in GI surgery, and um, he should have been the head of the department, but because he's the main person who looks after Manipal GI surgery unit, and he has his own unit. So, with his permission, I shall start sharing his um, screen. So, just a moment. Let me just um, give me a bit of time.
thank you Dr. Debakshi.
So let me just get your.
Yeah.
So now I shall start sharing. Just tell me, Dr. Mondal, whether you can see the screen, and what I'll do is I'll go into the presenter view. Is
Yes, sir.
that
Screen is visible, sir.
okay? Right.
Yeah, I can see the presentation.
Okay. So thank you, Dr. Mondal, for taking time off of your very busy schedule. So we are going to talk this evening on approach to borderline resectable pancreatic cancer. And for a start, I'm going to ask you, please define for me what is borderline resectable pancreatic cancer.
Before I begin, I'd like to thank Dr. Sanjay Debakshi for this invite, and I'm extremely honored to be a part of this. Thank you, and it's a great initiative. Thank you. When we talk of borderline resectable pancreas cancer, we must understand that this was a concept which is actually first floated in 2001 in a paper by Mehta et al. And subsequently, the term at that time it was called marginal resectable. And then in 2006, from the MD Anderson Group, Vardhachari coined the term borderline resectable pancreas cancer. And from 2006, it was first adopted by the NCCN guidelines. Now, this was essentially an anatomical definition, which in which it was a technically resectable pancreas cancer, but with chance of high margin positivity. Now, if you look into the criteria, how to define, the criteria is essentially based on anatomy with regards to the information that we get from radiology. And on the radiological findings, it is mainly based on the involvement of the veins and the arteries. Veins include the SMV portal vein, the celiac artery, common hepatic artery. Now, it is on the basis of vein involvement. If there is more than 180 degrees of vein involvement, it is called borderline resectable. It can be less than 180 degree, but if there is contour irregularity or occlusion, but there must be a possibility of complete resection and reconstruction. Now, when this term, this language was put, possibility of complete resection and reconstruction, it was very vague. So later on, this was modified to include tumors which did not extend beyond the lower border of duodenum, because it was felt that tumors going beyond the lower border of duodenum would essentially be unresectable tumors. With regards to arterial involvement, if there was a celiac artery involvement of less than 180 degree, or if it was more than 180 degree without aortic involvement, and the gastroduodenal artery remaining patent, which allowed an Appleby type resection without reconstruction. And for the common hepatic artery involvement, the criteria was that yes, common hepatic artery could be involved, but the celiac axis and the proper hepatic artery needed to be free. So these were the basic anatomical criteria on the basis of which borderline resectable pancreas was defined. But then two more criteria were added later on. And these criteria were the biological criteria and conditional criteria. Now, the biological criteria essentially
So
meant that,
before we, Dr. Mandal, before we get to that, it's
yeah,
all,
yeah,
you've named a number of vessels.
yeah.
Can you please explain, can you explain it anatomically? I mean, why is the lower border of the pancreas, of the duodenum so important? I mean,
Yeah, yeah. The lower border of the duodenum is important because when the tumor extends beyond that, the length of the vein, the more length of vein is involved, and the second jejunal branches get involved, which make
right.
it technically unresectable, and that is why it was defined as it was objectively defined to take the lower border of the duodenum as the cutoff.
So, I mean, do you have groups out here, because your diagram that you've drawn out very kindly
Yeah,
for us,
yeah.
can you explain the groups for our attendees, please?
Yeah. So basically, the groups are, you have to remember that group D, anything going below group D. Group D is a tumor which is technically non-resectable.
Right.
All tumors above group D remaining with the criteria would be borderline resectable. And if it goes beyond the borderline resectable, it is termed as locally advanced pancreatic cancer.
Right. Okay. Well, that's very clear now. But you were talking of something like a biological criteria.
Yes, yes. Now, the biological criteria, which was included later, actually means that on the basis of this biological criteria, these tumors possibly could have distant metastasis, but which are not picked up either on CT or PET. And the criteria which they have used is a high CA 19-9, which is more than 500, or suspicious regional lymph nodes on CT or PET CT.
But
These
you
are
were
not biopsy. Yeah,
uh,
these are not biopsy, but there is suspicion, and these would include these are the biological criteria. And of
so
course, there's a yeah, yeah, please.
so these would make. I mean, the implication is people with this sort of a situation would have chances of distant mets, isn't it?
Yes, they would have a high risk of distant mets, and these would make this patient's borderline resectable. Though on radiological finding, you're not seeing any distant mets.
I see. I
So
see.
these patients would also fall in the borderline resectable criteria.
But you were talking also of a conditional criteria.
Yes, the conditional criteria essentially is with regards to the patient's overall performance status. So on the ECOG score, if the performance status is 2 or more, or the patients have severe comorbidities, then again they would fall into the criteria of borderline resectable, and
Right.
they would be managed according to the borderline resectable criteria.
So if we have, I mean, since we are talking of radiology, if I were to show you some CT scans, could you
Yeah,
take us through them?
yeah. Uh, so, yeah. Okay. So what we have, the first CT that we have starting from the left side on the top, as you can see, this is a head mass which is abutting on the on the vein, portal vein, and you can see if you look at it, it's almost 180-degree involved. The abutment is 180 degree. It's not involved, but it's 180-degree abutment. So this would fall into the criteria as borderline resectable.
Right.
And on the other sections, the abutment is less, but as long as in one section there is an abutment of at least 180-degree, then or more, it becomes a borderline resectable.
Right. Okay.
And
So,
apart from that, obviously there are no distant mets, and I don't see any nodes at this in this city, but I think we'll need more sections to
I
see
mean,
that.
even on the section, I mean, would the involvement of the aortic cable node be important?
Yes, definitely. If there is involvement of the interaortogaval node, it is technically stage 4 disease, it is a metastatic disease, it is an M1 disease. And generally, these patients would not be considered for surgery.
I mean, for example, I mean, this patient has a suspicious lesion out here. If you can see the first on your first, the extreme upper extreme left.
Okay,
Uh,
okay, okay. Yeah, not yeah, I couldn't appreciate well. Yeah, okay. These are small nodes. Yes, these are nodes. I need to know the size of these nodes. And probably in these patients, EUS would be better to discern, and an EUS
right.
guided biopsy might be helpful.
Okay, so that would be an additional thing that the patient needs to have to
Yeah,
actually stage the disease,
yeah,
isn't
yeah,
it?
yeah.
Okay, then tell me something. I mean, in stomach cancer, we hear a lot of neoadjuvant therapy. Is there a role of neoadjuvant therapy in a pancreatic cancer?
Yeah, actually, look, traditionally, I think these borderline pancreatic cancers were treated with upfront surgery. Now, the problem with upfront surgery was that uh, these patients tended to have micrometastasis. Uh, and if you operate them, these patients tend to come back with recurrence. The positivity of the margin was higher in these, and Whipple's surgery is obviously a major surgery, and after undergoing Whipple's surgery, a lot of these patients would not be very fit to undergo an adjuvant therapy, which was required in a lot of these. In fact, only 50% would ultimately end up getting adjuvant. So this is where the neoadjuvant came in. And because the traditional approach had poor survival, the neoadjuvant therapy, which is upfront chemotherapy followed by surgery, followed by adjuvant therapy, came into the picture. And there were a lot of studies which compared this group of patients with the group of patients who just underwent upfront surgery followed by adjuvant chemotherapy. And
Okay.
you can see this table actually illustrates quite a few randomized trials, quite a few meta-analysis. What is apparent in this is that though the resectability rate did not improve much between these neoadjuvant group and the upfront surgery group, but what was clearly evident was the R0 resection rate was much higher in patients who underwent neoadjuvant therapy. And as a result of the higher R0 rate, the overall survival was better and the disease-free survival was better. And this is very important because when patients end up with an R1 or an R2 resection, especially R2, the prognosis is as bad as not operating them at all. So,
Quite right.
yeah, R0 resection is probably the most important determining factor in these group of patients.
I mean, that's a beautiful chart, but I mean, for purposes of the viewers' convenience,
Yeah.
do you have a graph to represent
Yes, yes.
and what are
Yeah,
the
I think
different
the
types of neoadjuvant therapy, and is there a difference between them?
yes. This graph actually, which you have shown, actually is one of the studies which shows how the long-term survival is better in the neoadjuvant group. And they have actually had couple of neoadjuvant groups in which there was radiotherapy combined also and upfront only surgery. And they have showed that patients who undergo neoadjuvant therapy definitely have a better survival. But the issues with neoadjuvant, couple of issues do remain, and that is what is the optimum duration of neoadjuvant therapy, whether it is 2 months or 3 months, and as you asked, what are the chemotherapeutic regimes which are available with us. And if we look at the chemotherapeutic regimes available with us, I think we have most, I mean, well known is the FOLFIRINOX, which is a combination of 5-fluorouracil, leucovorin, irinotecan, and oxaliplatin. You have a modified FOLFIRINOX. You have gemcitabine plus other chemotherapeutic agents. You have gemcitabine plus nab-paclitaxel, and you have gemcitabine as a single agent. Now, these are the main chemotherapeutic regimes which are available. And of these, probably FOLFIRINOX has the best results, but it is very toxic and is recommended only for patients who are very fit. So if you do not have a very fit patient, it is probably better to go with something like a gemcitabine with nab-paclitaxel. And actually, studies have shown that if the patients ultimately do undergo surgery, there is not very much difference between FOLFIRINOX and gemcitabine with nab-paclitaxel. So any one of them can be used to have a good outcome.
There was another concern, Dr. Mandal,
Yes. Yeah.
two concerns.
Yeah.
I see that your chemo radiation didn't do all that bit better than pure neoadjuvant
Yeah,
chemotherapy.
yeah. I think I mean, compared to chemotherapy, which has shown conclusively better outcome, the role of radiotherapy has remained very controversial. In fact, there was one study from MD Anderson, I think it's the Alliance trial by Matthew Katz, and they actually showed that if you give radiotherapy, the outcome was far worse. And there has been some studies which have shown better results, but overall, it's a mixed picture. The addition of radiotherapy remains unclear and no survival benefit actually has been proven. So generally radiotherapy is not as it is recommended, though in the NCCN guidelines it is there, but it is not very strongly recommended and most oncologists just give chemotherapy to most of the patients. However, it may improve local control and it may be of benefit to some patients or those patients who ultimately do not undergo resection. So in this group of patients, probably radiotherapy would have a role.
All right. Okay. I mean, you've also sent over a graph which
Yeah,
shows an overall borderline resectable pancreas cancer, which is
yeah,
resected following chemotherapy.
yeah,
Uh, I mean, this group, as you have shown, there is one which has chemo without any specification. Various groups, gemcitabine based
yeah.
monotherapy, FOLFIRINOX. So, is there a lot of difference between them? I mean, we said that FOLFIRINOX was quite toxic, and one of the concerns was when the original trial started was that once the patient had a difficult Whipple surgery, most dropped out of completing the course of FOLFIRINOX post surgery
Yeah,
adjuvant
yeah,
therapy.
yeah, yeah. Yes, FOLFIRINOX is definitely more toxic, and there were concerns that if you give it pre-operatively, you would have a few patients which would drop out, which would, and that was actually taken into account. And if you look at the previous table that I had shown, most of these randomized trials and meta-analysis actually looked into the intention to treat analysis, and on the intention to treat analysis, actually the chemotherapeutic the group which received chemotherapy and FOLFIRINOX did actually give better results. So in
Right.
spite of patients dropping out, it ultimately did give a better result in patients who underwent neoadjuvant therapy.
Right. Right. Dr. Mondal, you were talking of borderline resection. I'm just concerned, what is the role of venous resection, um, you know, as opposed to, where do we stand right now
I
in terms
think
of,
Yeah, I think if we compare conventional uh, pancreatic duodenectomy with venous resection, and they have number of studies available. Not all of them are randomized, but yes, there are a number of studies, and they have actually shown that the long-term survival is not much different as long as you do an R0 resection. In fact, patients undergoing venous resection vis-a-vis conventional resection had same long-term survival. What was a bit problematic initially was that patients with venous resection tended to have a higher mortality. It was around the tune of more than 5%. But
Right.
with more experience, the high volume centers brought it down to about 2 to 3%. So that hurdle was crossed. And once that hurdle was crossed with similar outcome, it is actually recommended that if you have a venous involvement, you should do a venous resection. The
Uh,
only issue is that, yeah, please.
yeah, go ahead. It's just that, I mean, on that table, this table in particular,
Yeah,
we are doing pancreatectomy with venous resections in people who have borderline resectable uh, pancreatic cancer,
cancer.
as
Yeah,
opposed to conventional PD where the vein is completely free. You can
yes,
get away
yes,
with it. So,
yeah.
I mean, are we actually comparing biologically worse tumors with better tumors, and the results are equivalent, isn't it?
Exactly. That is what is been pointed out, that you have a biologically worse tumor, and compared to that, the better tumors, if you compare them, the results actually come out same as long as you're doing an R0 resection. So that is why it was recommended that vein resection should be done, and it should not be a hindrance to unresectability in these patients.
Right. Now, for the people who are attending, for them, I mean, will you tell us, work it out? Is venous resection safe? You were talking of mortality, and
Yes.
is there a sort of preparation that goes into, you have somebody with a borderline resectable uh, pancreatic cancer? How do you prepare for it?
Yeah. So the preparation of these patients is two steps, I think. One is that since these patients would undergo neoadjuvant therapy, these patients would also have jaundice. So the jaundice needs to be brought down. No oncologist is going to give chemotherapy with the patient of jaundice. So in the bilirubin needs to be brought down to at least less than 3. And most of these patients would benefit from a biliary drainage by ERCP and stenting. So it's either a plastic stent, or these days a lot of people are putting metallic stents. Metallic stents bring down the jaundice quicker. And previously there was a hindrance that metallic stents can make surgery difficult, but that's no longer so. We are operating patients with metallic stents, so that is not a problem. So you can put any stent. If for any reason ERCP is not possible, then a PTBT should be done. Uh,
Right.
the problem arises in some patients where the bilirubin does not normalize. And that could be two reasons. One, the stent gets blocked repeatedly, or the stent is not enough, in which case you might need to upgrade from a plastic to a metallic stent. And the patients might have an underlying chronic liver disease, which needs to be ruled out before you start with chemotherapy.
Mm.
The other aspect of preparation of the patient is the tissue diagnosis. And this is important because, again, without a tissue diagnosis, most oncologists are very unwilling to give chemotherapy, and it would not be right also. In these group of patients, the modality of choice for getting it is an EUS with fine needle biopsy. And I
Right.
specifically would stress that it's a biopsy and not a cytology, because the yield rate in biopsy is about 70%. In cytology, it would be 30%. So it is a biopsy which is most important in these patients. So if you don't get with one biopsy, you might end up repeating another one to get a diagnosis. Uh, can I add one more thing, that again a
Yes.
problem happens that some patients may end up with negative biopsies. So what do you do with those patients? Now, if a patient has an obvious clinical or radiological features of malignancy, and you have conclusively ruled out chronic pancreatitis and autoimmune pancreatitis, the patient is otherwise well informed, then in a high volume center and the multidisciplinary team or the tumor board agrees, even after two negative biopsies, one can go ahead with giving chemotherapy to these patients. But then it has to be decided by the multidisciplinary team. So this has to be kept in mind.
So that's a strong message to go around, isn't it? That you
Yeah,
must get the MDT to agree to give a neoadjuvant chemotherapy,
yeah,
isn't it?
yeah. Yes, and what I said is we tend to have a lot of chronic pancreatitis which masquerades as mass autoimmune pancreatitis, so those must be ruled out.
And the way actually is really the point that you made. It's an endoscopic ultrasound guided true gut biopsy, not a FNAC, isn't it?
FNSC, yeah, it's an FN fine needle biopsy, actually core biopsy.
So, given the fact that a vein is involved, do you have different ways of approaching that? I mean, do you have different ways of venous resection and reconstructions?
Yes. It's very important that, as I said, preoperative planning is required. Intraoperative approach, respecting the oncological principles are important. And during surgery, one has to minimize the bleeding and minimize the bowel and hepatic ischemia to get a proper outcome and decrease the mortality and morbidity. Now, I mean, it's a big topic, but uh, the surgically you have to mobilize everything properly, and for vein resection generally the vein resection has to be left for the end. You need to almost mobilize everything, and very important, we will be talking about it later, I think the arterial involvement has to be ruled out before we go ahead with the vein resection.
Sure, sure,
Sure.
absolutely.
Yeah. And just to add that if a small part of the vein, say 30% of the circumference is involved, 20-30, you can get away with a sleeve resection, which is relatively easy to do. But if more circumference is involved, then you would need an end-to-end resection with anastomosis. Most of the time, with good mobilization of the liver and the duodenum mesentery, you would be able to bridge around at least 2 to 3 centimeters of gap, sometimes up to even 5 centimeters. But if it's more than that, then I think we would need to replace it with either a vein graft, autologous graft, or an artificial graft. And these need to be planned together. And if required, I think getting a transplant surgeon involved, or probably a vascular surgeon, a transplant surgeon will definitely be better because they deal with these things regularly, would be quite beneficial, and it will be helpful for the surgeon.
Great. Dr. Mandal, I'm going to stretch you a bit further. Now that we are talking of venous resection, what is the role of arterial resection?
Yes. Now, this is very interesting because, like in venous resection, the outcome is better and it's proven. The For arterial resection, the long-term survival has not been good. On top of that, arterial resection is associated with higher mortality. In fact, previously the mortality is about 15%, 10, more than 10%, going up to 15 or even more. These days, in high volume centers, the mortality has come down to around 5 to 6%, but still on the higher side. But more important is that the long term survival in patients who have arterial involvement is not good. In fact, it is much lower, and hence arterial resection has not proven to be of benefit and generally not recommended. However, however, you will find that some people go ahead and recommend a celiac axis resection, but not an SMA resection. Probably that stems from the fact that you can do a celiac axis resection and it's very difficult to do an SMA resection. So it's probably comes down to the can do and will do, and can't do and will not do stuff.
So, I mean, do you have systemic reviews of, arterial resection?
Yes, I think this table actually has quite a few studies where arterial resections, and different type of arterial resections were done, uh, which included pancreatic adenectomy, distal pancreatectomy, total pancreatectomy, and it was combined with portal vein resection. Now, a lot of these have actually just done celiac axis resections, or probably the common hepatic artery resection. Few have done SMA resections, and the mortality does remain high. The long-term survival is not very great. Resection margin positivity has remained high in this. So, bottom line is that generally arterial resections are not recommended.
Right. But I remember going back to one of your previous statements that when you're doing a venous resection, you must make sure that the artery is free. So
E-
I've heard of something, we talk a lot about artery first approach. What is the artery first approach and what
I
are
think
its
that's
advantages?
Yeah, I think for that we need to go back a little to how we did the conventional Whipples. Now, when we did the conventional Whipples, if we all remember, we would try and create a tunnel in front of the portal vein and SMV portal vein. And once that was done, we would transect the pancreas and go ahead with the resection. Now, problem with this is that after you had committed yourself to resection, at the much later stage, when you're trying to take the uncinate out, you might find involvement of the artery, especially with tumors of the uncinate. And then the surgeon would be in a fix and he would end up doing an R2 resection. So, and doing an R2 resection is absolutely not beneficial for the patient and neither for the surgeon, because you work hard for 6 hours or 8 hours and then you find that the patient comes back with a recurrence within 6 to 9 months. So that's not beneficial. So it is very important that we assess the artery at the very beginning before transecting the pancreas and assess that it is not involved. Then only we go ahead with the pancreatic neck transaction. The other additional advantage, as mentioned here, with arterial first approach is that there is less blood loss. At least it's considered that there should be less blood loss, better margins, more lymph node harvest. And if you do an artery mobilization, it is also better for the venous resection.
Um, a question again. Are
Yeah.
there different types of artery first approach? I mean, different approaches to the artery.
Yes. Here, this is a list of the different types. But what I would like to say is that there are two main types. One is the posterior approach, and one is the medial uncinate approach. Now, the others are more or less the modifications of these approaching the artery from different planes. But it is these two approaches which are most commonly used. Sometimes they are used independently, sometimes used in combination. I would use both of them in combination because I find it easier to do that. Now, essentially, what is done is that the whole pancreas, the colon should be totally mobilized by a cattle brush maneuver. Once the colon is taken down, the duodenum should be totally mobilized, taking it off the IVC and the aorta. So you're able to visualize the left renal vein. Once you visualize the left renal vein, you would be able to see the superior mesenteric artery going into the aorta, just crossing the left renal vein. Now you start in the posterior approach, you would start dissecting from that towards the downwards towards it. And there are three vessels that you need to ligate to ensure that the artery is free. And that is the inferior pancreatic duodenal artery and vein and the first jejunal vein. So these need to be ligated either from the posterior side or when you're doing it from the medial side. And when you're doing it from the medial side, you tend to sling up the SMV, retract the SMV, and approach the from below the SMV, going to the medial side to identify the artery and exposing the artery from there. So these are the two main approaches.
Okay, right. So, I mean, I think you've drawn diagrams out here,
Yeah,
which you've adequately explained.
yeah,
Um,
yeah.
but do tell me, I heard of something called the derotation approach. What is the derotation approach?
Yeah, derotation approach is something like this. If you remember your embryological anatomy, and you remember that there is some patients come to you with malrotation of the small bowel.
Right.
So when they come with malrotation of the small bowel, what we end up doing is we tend to bring the whole of the small bowel towards the right side and push the large bowel towards the left side. So that is what is done in case of derotation. So if you see this picture, the small bowel is rotated below the axis of the superior mesenteric artery and vein to bring it to the left side. So when you bring it to the left side, the it's supposedly said that the plane absolutely opens up, and normally where the vessels, the inferior pancreatic duodenal and the first jejunal would have been located very deep posteriorly, comes to lie in front. Now, I personally have never done this, but this I have read up in literature that this is one of the approaches which the Japanese have come up with, and it is a modification of the Sugiyama approach. And it makes and they have said that this approach is actually good for the novice surgeon or the surgeon who is recently trained. And the previous two approaches, which I mentioned, are better for those who are more experienced.
Right. So, I mean, if somebody was starting off doing artery first, you would recommend a derotation, is it?
I since my experience in this derotation stuff is low, I have just read it in literature, so I cannot
Right.
recommend it as such. I would at least tell whoever is a novice person to start learning it from your seniors, the conventional approach, and then of course you can try this.
Right. But I mean, talking of artery first, does it actually improve R0 resection?
Yeah, it on paper, yes, probably because you are dissecting of the artery first. But there have been studies which have shown mixed results. In fact, this study which I have illustrated here is a randomized study, and they have shown that the R0 resection rate was no different, and the perioperative mortality was also not different. But there is a caveat to this in the sense that this study had patients which were straightforward resectable pancreatic cancer also. And
Right.
in patients of resectable pancreas cancer, where the tumor is pretty far from that, actually it does not make a difference whether you do artery first or you don't. Artery first is important in the borderline and the locally advanced pancreatic cancer. So unless you are specifically taking these patients, I don't think you will get actually an proper result-oriented outcome from your studies.
So, I mean, that is the confounding factor for
Yes.
this paper, isn't it? I mean, because
Yes.
if you're addressing tumors which are, easily resectable,
Yeah.
not borderline, that obviously there's not going to be much of difference. So you
Much of the
really,
exactly.
you're comparing apples and oranges, really,
Exactly.
isn't it?
Exactly. Exactly.
So, do you have any other, paper on which is or any other information regarding, borderline resectable tumors having an artery first versus a,
Uh,
um,
Actually, I have not come across any paper which addresses borderline, but there is a paper from Dr. Shailesh Shikhande, which also says that I mean I think in that paper could not find much difference in that. But
okay.
still, I'm sure he recommends doing the artery first because we still feel that the other advantage is that if you do the artery first, your dissection is done so well that
Yes.
when you're ultimately going after you've transected the pancreas, you don't have much to do after that. Your thing is totally I mean mobilized, and your the retroperitoneal posterior dissection is very straightforward.
So, I mean, just tell me one thing. If, I mean, you've got a pancreatic head cancer, would your choice be an arterial first approach? Never mind what the tumor state is. I mean, because of the easier dissection.
We would do an artery first approach. We have started doing that regularly in our patients. And it actually, the thing is that it does not lead to any increased time. The only thing is that a lot of dissection, which we are doing later on, we do it before. So we do it before transaction. So it actually helps in the long run.
So essentially, you land up with a better operating field, isn't it? I mean,
Exactly.
cleaner
Exactly.
operating field. Um,
Exactly.
I'm going to stretch you a point again out here.
Yeah. Yeah.
Arterial involvement. I have heard, papers coming out from Europe and USA of something called divestment. What is arterial divestment?
Right. Now, the arterial divestment is actually, I think, came from China first. Then a lot of people started doing it from Europe. It is a procedure by which you dissect between the tunica, adventitia, and media. And this is okay for where the tumor is just involving the adventitia. So you try to dissect between the adventitia and media and dissect the whole tumor, strip the whole tumor off, cut it at one point, and we remove the tumor like removing what do you call a wrapped up cloth, and you get away with removing the tumor without doing an arterial resection. So the morbidity of arterial resection is spared, and you are able to do a R0 resection. But a lot of purists say that divestment is not a pure R0 resection. It is in fact an R1 resection. But those who have done it have shown good results with it. But I think we need more studies with regards to this. But yes, this is a way in which you can resect the tumor and get a sort of R0 resection in most of these patients without
But,
doing an arterial
but
resection.
Dr.
Yeah.
Mandal, don't you, I mean, is there a higher incidence of post-op aneurysm forming because you've left the artery without, fairly major arteries coming off
Yeah.
the aorta without its adventitia, isn't it?
Uh, yes, probably, but just taking off the adventitia because you're leaving the media tunica media behind. If you're removing part of the tunica media also, then probably the chances are higher. But just removing the adventitia probably does not lead to that higher chances of aneurysm. But yes, theoretically, I'm sure there is a chance, but not that much.
It sounds like a very difficult operation, just taking the adventitia off the media. Uh, you know, what do you think?
Yes, yes, it is difficult. Personally, I have done it in just a few cases. That too, I think those patients had didn't have I mean, circumferential involvement, had a unilateral, involvement of one side, and we were able to dissect off it off the tunica media, and the why I am saying this is useful is that when we look at the histopathology of a lot of these vascular involvements, you will find that in spite of clinically appearing involved, only 40% actually show histopathological involvement. So a lot of these patients actually do not have an involvement. And if we did not do this, at least 60% of these patients we would have abandoned, thinking it to be unresectable.
Right.
So I think this actually helps. Not probably, at least if not in the involved patient, at least in those 60%, it gives you a way to take out the tumor and give them a chance at resectability.
But point being taken because adventitia is also a border where the tumor might get involved and get stuck.
Yes,
It's
yes,
difficult for the tumor to go beyond the adventitia. I think that was the basic idea, isn't it?
exactly, exactly, exactly.
It's a sort of a fascia. I mean, the closest analogy I can get is a fascial, break to the tumor.
Exactly, exactly.
Um, I have heard of, and I'm going to ask you, what is the triangle operation?
Okay. Now, this actually, this triangle operation is a part of the pancreatic resection, and it came from the Heidelberg group in Germany. They have defined this triangle where the one wall is formed by the celiac axis, one by the common hepatic artery, one by the celiac axis and common hepatic artery, one by the portal vein SMV, and one by the SMA. And they have said that all soft tissues and lymph nodes in this area have to be cleared. And this actually increases the resectability because this actually is a part of the posterior margin or the retroperitoneal margin. And it increases the lymph node yield and probably leads to a better survival. Now, if you really want to see it, you have to wait for the randomized trials. As of now, with regards to survivability, we do not have the long-term randomized trials from Heidelberg. They are yet to come. But we do have some short-term results from their series with regards to this. And they have what they have found in the short-term randomized studies is that triangle operation leads to increased duration of operation, increased intraoperative blood loss, increased use of abdominal drains, and increased ICU stay, and increased postoperative diarrhea. So these downsides are there with the triangle operation. However, yes, they have shown some increased R0 resectability rate and increased lymph node yield in certain subgroup of patients. But then again, it is a difficult operation. Uh, I do not do it because I have found that area to be very difficult to approach at times. This photograph was given by my good friend Dr. Ravi Shankar, who does it in a few cases. But we need to see whether this actually is leading to a better long-term result or not. That is very important.
It seems to me that there's always a very thick sheet of nerve plexuses out there as well, isn't it? And that
Exactly, and
probably,
that makes the dissection in that area very difficult. And that's why they doing a triangle operation done in a few cases and found it to be very difficult. There is blood loss, and while doing one, we at least had one venous injury we had to repair after that.
right. So it's something that, one needs to be cautious about before.
Exactly.
Uh, so, I mean, tell me, what's the difference between a, triangle operation in terms of pancreatic or duodenectomy and total pancreatectomy? And before we get, I mean, what is the role of total pancreatectomy? I'll ask that later. But if you can, I mean, go through this. Um,
Yeah, this actually, which I had said that it leads to increased post-operative complications. But what they have found is that if you're doing a total pancreatectomy in
right,
place of a pancreatic or duodenectomy, doing the triangle operation becomes much easier.
sure.
And in those group of patients, there is probably not much difference, because when you're doing a total pancreatectomy, you end up removing most of the structures. And once the pancreas body gets removed, the area is much more better exposed to do that operation. So, compared to pancreatic duodenectomy, in total pancreatectomy, the triangle operation basically becomes much easier with less post-operative morbidity.
So that explains why there's difference in diarrhea, isn't it, between the
Exactly.
pancreas? Okay, right. So
Exactly.
because, I mean, if you were doing a total pancreatectomy, you would have the same number of patients having diarrhea, if you were doing a
Ex-
standard versus a triangle, isn't?
exactly. Exactly.
Okay, right. So what is truly the role of a total pancreatectomy?
Um, I think we have illustrated it here. If you have, while doing the surgery, if you have tumor extension going into the body of the pancreas, that's one. Or you have not overt involvement, but you have resected and you send the margin for frozen and you find margin positive, then you might take another further extension of the margin, or you might go ahead and do a completion total pancreatectomy while in the same setting. If they are multifocal tumors or in the setting of IPMN, would be indicated for a total pancreatectomy. Now, in the setting where you're doing arterial resection, especially an SMA resection, now in this setting, a pancreatic leak, pancreatic jejunal leak, which is not very uncommon, would lead to a catastrophe. So, in the setting of arterial resection, it is recommended that if required, you can go ahead and do a total pancreatectomy. The other situation is where you have a very small duct, a very soft friable pancreas where your sutures are cutting through. You can go ahead and do a total pancreatectomy. And in a very subgroup of patients where post-operatively you have had a complication, which can be a leak, and you go in to operate these patients, you might end up doing a completion total pancreatectomy. So these are basically the indications of doing a total pancreatectomy.
So I have a question. I mean, I've heard of, the evolution of very brittle diabetes after a total kind of pancreatectomy. What's your experience of
Uh,
controlling blood sugar after a total pancreatectomy?
Yes, I mean, if you had asked me this question maybe 10 years before, I would have said no, I would never do a total pancreatectomy, because at that time the blood sugar and diabetic control was very difficult. Yes, these patients have a very brittle diabetes, very difficult to control. The sugars just shoot up. Then you give insulin and the sugar just falls very low. And it becomes very difficult. You need to do sugar monitoring very rigorously. Now, 10 years back, we probably didn't have that amount of backup from the endocrinologist. But nowadays, we have a lot of better sugar monitoring, what do you call, instruments. We have a better endocrine backup. And probably today, as of today, yes, we would, I mean, think of total pancreatectomy much more strongly than we did 10 years back.
Right. But also, I want you to explain why, if we were doing a SMA or a CHA resection, why would a total pancreatectomy be something that you would need to consider?
If you're doing a CHA resection and reconstruction, especially, and you do a partial pancreatectomy, there is an anastomotic leak, the enzymes tend to erode vessels. And in case of a standard Whipple's, the most common vessel which is eroded is the gastroduodenal.
Okay.
In these patients, if you have done a resection and a reconstruction of a vessel, the site of reconstruction may erode and you have an aneurysm and a flow out. This is very difficult to manage. And that is why in this situation, a lot of people would recommend doing a total pancreatectomy.
Because you would balk at having somebody doing a coiling of the SMA, isn't it?
Exactly, exactly, exactly.
Right. So do you have any other take-home messages, any other pearls to share with our audience?
Uh, I have this final take-home message just to say that borderline pancreatic cancer is a distinct entity. It is different from resectable pancreas cancer. It's distinct from locally advanced pancreas cancer. Uh, you need a multidisciplinary approach. You need a tumor board to sit down and decide the management. Neoadjuvant therapy is now the standard of care for most of these patients. Surgery should only be attempted in optimized patients after restaging. And I forgot to talk about restaging. We can talk about
Yes.
it. Yes.
Can
And
we do that?
obvious, yes, we can do that. And just to mention that the goal should be an R0 resection. Now, talking about restaging, we had mentioned that you give neoadjuvant therapy, and the duration of neoadjuvant therapy should be generally people would give 2 months or even 3 months. And then ideally, these patients should be restaged. Now, there are two modalities by which they are restaged that should be done, both of them. One is seeing the CA19-9. So if you find a patient who had a high CA19-9 and CA19-9 has come down, you will know that this patient has probably responded. If it is a stable or an increasing CA19-9, there is some problem, and these patients need probably you need to avoid doing operation surgery in these, and these patients probably need further chemotherapy, or you need to add radiotherapy to these. The other modality that we need to do is a CCT upper abdomen with pancreas protocol, which is probably the investigation of choice for evaluating pancreas cancer. We didn't talk about it, but that is one thing I would like to tell our students. Now, when we do a CCT assessment for these patients, we must understand that only about 1% would show very significant radiological response, and only 10 to 15% would meet the RECIST criteria for tumor response. But almost 80% would be resectable. Now, the issue is, why is this so? This is because CT is not able to actually assess the response properly. The idea of doing the CT is to look for progression. So if a patient does not have progression of disease on CT, you are good to go ahead. The theory is that chemotherapy tends to destroy the tumor cells in the periphery, and you would be able to get negative margin and R0 dissection, even though on CT it shows that the tumor has not shrunken in size. However, there are two modalities which are being investigated for assessing the neoadjuvant therapy, and one of them is the FDG PET CT, which they say could be better, especially if it is showing an SUV max reduction of 40 to 60%. However, again, please remember that in patients who have undergone a pre-op radiotherapy, patients tend to have false positives because radiotherapy tends to give a lot of inflammation and edema. And if you do a PET CT very early, then you will get false positives. So delay the PET CT by 6 weeks if you have given radiotherapy. The other aspect which we must remember is that neoadjuvant therapy leads to alteration of the blood sugar levels and this can interfere with the PET, and that needs to be kept in mind. The second modality, which is still under investigation, is an MRI with pancreas protocol and diffusion weighted imaging. So these are two which are coming up, but we need more studies to see whether they are actually helpful or not.
Right. Um, I mean, like in rectal cancer, MR won't be a better option. You don't think an MR is a better option? A contrast MR is a better option than a CCT? Just
As of now, still investigational. As of now, the standard recommendation is a CA19-9 and a CCT upper abdomen pancreas protocol, not an MR with diffusion weighted imaging. but it is the CCT which is recommended. But yes, there are some studies which have shown that the MR with pancreas protocol diffusion weighted imaging might be better.
Right. So that was an excellent uh, discussion on borderline resectable pancreatic cancer. An excellent take-home message. So I'm going to ask Dr. Sinha, are there any questions from the YouTube? I can't see the questions on the YouTube, but I can see questions in Zoom. So
Mm. Okay, are there questions?
Shilajeet, are there any other questions? Rudrajit, are there any other questions? So if there aren't any other questions, it only remains for me to thank Dr. Sanjay Mandal. Dr. Mandal, thank you very much. That was
Thank
a
you. It has
very,
been my
very,
pleasure.
very, very extensive discussion. You live and learn every day. I'm glad I was here.
Thank you.
Thank
Thank you,
you.
Sanjay. It was my pleasure. Thank you.
Thank you. So I'm going to stop share. If there are any other questions, finally, we can take them. Otherwise, I'm pretty sure that if you pass on your messages, on your questions later, either on our YouTube channel or on the WhatsApp students group, I'm sure I can pass them on to Dr. Mondal and he'll be only too happy to take them. So thank you, Dr. Mondal. Thank you ever so
Thank you.
much. Thank
Thank
you.
you. Thank you very much. Thank you. My pleasure.